Welcome to my medical student's guide to making patient presentations. I'm Marco Tan, an emergency physician and graduate of the class of 2006. In this presentation, I'm going to go through some basic concepts underpinning what makes a good patient presentation, as well as showing a hypothetical example. The concepts I'm going to go through here are not the last word in making presentations, but they are some tools to give you a good foundation to build upon as you start your career. Presentations are an opportunity to show off your work. In this case, I mean your mental work. Presentations are an opportunity to show that you have not just collected information from the patient, but that you have organized it and synthesized it into a cohesive assessment, diagnosis, and plan. Show your work by telling your listener more than just your findings. How you present the information makes a big difference. If you just report the findings without an assessment and plan, you've only done part of the work. Your assessment and plan is basically an analysis of the situation. Strive to show that you've taken that next step. That is, making an analysis of the situation. Think carefully about what details you will put into your presentation to showcase your work. Use the details that drive toward your conclusion. In essence, you are defending your conclusion even before you reach it. So keep your conclusion in mind throughout the presentation. Presenting with your conclusion in mind helps focus details. This will hold true over many styles of presentation. Many presentation styles exist, some shorter, some longer, some with a more rigid structure, some with a less rigid structure. This underlying concept will help you regardless of which style your senior residents or your attendings prefer. The next few slides will show a single simplified example to illustrate the principles we discussed previously. Our example will be for a patient with a suspected small bowel obstruction. Note there are many potential ways to present this patient. We are just going to show one way to illustrate the principles of presentations that we discussed earlier. For the first section, we give some background information. So, our patient is a 60-year-old female with a medical history of hypertension and a surgical history of an appendectomy when she was 19. She takes amlodipine and no other medications. She has no allergies. She drinks 1 to 2 alcoholic beverages a week, no smoking. So this section gives us the background with which to understand the patient in the rest of the presentation. In the next section, focus on building the story in the HPI. So, she comes in complaining of abdominal pain for 3 days with vomiting and constipation. The pain is gradual, it's diffuse, not localizing to either side. It's 6 out of 10 in intensity. There's no associated factors that worsen or improve the pain. She took over-the-counter Motrin and Maalox over the past 3 days without relief. So this section focuses on highlighting the parts of the HPI that build up the evidence for a small bowel obstruction. The next section is the review of systems. For this, focus on key pertinent positives and negatives. So, decreased appetite, abdomen feels distended, nausea, vomiting, constipation, not passing flatus. There's no fever, no flank pain, no dysuria, no skin color change, no leg swelling, no gynecological bleeding. Note that the clustering of the pertinent parts of the review of systems helps to continue building the story of a small bowel obstruction in this patient. Next is the physical exam. Here we continue the focus on the key positives and key negatives. So, generally uncomfortable, abdomen, increased bowel sounds, distended in all 4 quadrants, diffuse moderate tenderness to all 4 quadrants, tympanic to percussion in all 4 quadrants. Dermatologic, no jaundice. Eyes, no icterus. Cardiac, regular rate and rhythm, no murmur. Respiratory, clear to auscultation bilaterally, no accessory muscle use. Neurological, cranial nerves intact. Note the strategic clustering of the pertinent details of the small bowel obstruction helps to make the story even more clear. Finally, the diagnosis. At this point, it should be pretty obvious. So, the patient's history and physical are consistent with a small bowel obstruction. The findings are not suspicious for liver, urinary, or gynecological disease. Note here that the thoughtful placement of the detail makes your diagnosis clear to your audience. If you place the details correctly, the diagnosis should be pretty obvious. Next, your plan. Now realize that your plan springs from your diagnosis. So, we should get pre-op labs, start fluids, and antiemetics. We should consider a nasogastric tube, and surgery should be consulted for a consultation. Note that plans are typically pretty straightforward after you've already established the diagnosis. Keep in mind that getting to the diagnosis or diagnoses is often the hardest part. Plans for further delineating diagnoses, assessing severity, and treatment are simple after you have a diagnosis or a short list of diagnoses. Without a diagnosis to hold it together, your plan can appear scattered and disorganized. Getting the diagnosis is a cornerstone from which your plan springs. Finally, a brief summary. Mainly, be thoughtful about the details you use. Present with your conclusion in mind to help focus details. Select details thoughtfully to showcase your work. And finally, tell more than just the findings, give an analysis.